And I hope my slides are visible. Anyone?
Yes.
Okay. So today we will be learning about just the sonoanatomy of lumbar spine, how exactly the things, of the spine, they just look like, under ultrasound. So let us first see the parts of the vertebrae, which is very important. So this is what you are seeing here, something like this here is your spinous process, right? The one which is down, this is your inferior articular process. You have two inferior articular processes from one vertebrae. And there is something which is going up like this. There is something which is going up from here. So they are superior articular process. And the lateral projections like this. This is your transverse process. Fine. Now this area which you are seeing, that is your lamina or lamina, whatever you want to say. Fine. And in between these two spinous process, you have one acoustic window. So this acoustic window is interspinous window. And this is one lamina and this is another lamina. So if I'm seeing it from the paramedian aspect, this window I am going to call it as interlaminar space or acoustic window. Fine. So how this vertebra roughly is, it has got two lateral projections. They are the transverse process. Two upward projections. They are the superior articular process. And two downward projections. They are the inferior articular process. Fine. Now, there is a ligament which is just covering all the spinous processes. It is supraspinous ligament. Then you have another ligament in between the spinous processes like this. This is your interspinous. As go back to my basic class, I have taught you that ligament is from one bone to another bone. So here it is from this spinous process to this spinous process. So it is interspinous ligament. And the one which you are seeing here, this is supraspinous ligament. Then we have ligamentum flavum. So L for ligamentum flavum and L for lamina. So this is the one which is from one lamina to the another lamina. From the, if you will see, it is on the anterior aspect of it. Then you have certain muscles. So you have an intertransverse complex between the two transverse process. You have this psoas muscle. Then you have this quadratus lumborum. And if you go, you have the multifidus iliocostalis and iliolumborum. So these are just a group of the rectus spinae muscles. Now, what probes you will be using to examine this? Mostly it is the curvilinear because we will be looking at a depth of approximately 7 centimeter. So if you're going to use the linear probe, its resolution is going to be very, it will not be having a good resolution to see the structures which are lying at a depth because it has gotten high attenuation. So there won't be good amount of beam which will be left to see the structures. That's the reason we will be going for this curvilinear probe. Now, in order to visualize the spinous process, we will be using this probe, right? I'll be showing you that. And you can have, you can just examine the patient in the lateral position, in the sitting posture, of course, in the prone position as well. As a pain physician, I prefer this position because I'm tuned to do all the interventions in the prone position. What will be the positions of the probe? So positions of the probe, if this is your midline, which I have denoted with this white paper, okay? So this is the center. If my probe is exactly on the spinous process, I am going to call it as median sagittal plane. But if my probe is just lying adjacent to the spinous processes, I am going to call it as paramedian sagittal plane, right? If I am tilting the footprint of the probe, maintaining the same orientation towards the midline, I am going to call it as paramedian sagittal oblique, okay, view. So we have we have median sagittal view, we have paramedian sagittal view, and we have paramedian sagittal oblique view. Sagittal, I hope by this time you are well tuned to that. Sagittal means we are just cutting the structures into right and left. Okay. And we are looking at the longitudinal axis of that structure. Now, once you go to the short axis or the axial view or the transverse view, you will have two views. Either your probe will be over the spinous process or your probe will be in between the spinous process. Okay. So now how are you supposed to examine? So there are two ways. Either you can come from the transverse process and you can just reach the spinous process, or you can start from the spinous process and you can go up to the transverse process. So it is up to you what exactly you want to follow. So first, our probe will be over the transverse process, right? If we are going to move our probe, so this is lateral and this is medial. So I am moving my probe in the long, like I'm talking about the sagittal views now. Okay, so our probe is in the longitudinal axis, as you can see with this bar which I have kept. So we are looking at the sagittal views. So we are moving from the lateral to the medial side. So from the lateral side, I have kept my probe over the transverse process. Then I will be moving my probe towards the midline. So the second structure which I will be seeing will be the articular process. As you can see here, this is the articular pillar view, right? And if I'm going to move further, I will be over the lamina. If I am going to move further, I will come to the spinous process. So how you have followed from the transverse process to the articular process to the lamina and then to the spinous process. You can do just the opposite. You can start from the spinous process, then the lamina, then the articular pillar, and then the transverse process. Now, this is very important that every view has got one typical, they have correlated with some of our, daily use things or some monuments or something like that, right? So this was given by Karmakar, Professor Karmakar. It's a very good article written by him. And this is like basically the views are from his article only. So what he has said that if you're going to put your probe over the transverse process, now this time we are looking at the sagittal views. Okay. So how the transverse process will be looking like to you? They will be like the fingers of your hand, okay? Or it will be like the trident of Lord Shiva, the Trishul of Lord Shiva we say, na? So we are going to call this transverse process view as finger-like projections or the trident view. So if my probe is over the transverse process, I am looking at the paramedian sagittal view. And if my probe is over the transverse process, they are going to have a finger-like projections or the trident view. Once I have moved my probe from this transverse process to this articular pillar, okay, like this. So this view, if you are going to see it, this will be like the hump of the camel. So this view, we are going to call it as camel hump view. Moving further, we will be over the lamina. How the view will be over the lamina? It will be like the head of a horse. Okay, so this view, we are going to call it as horse head view. And since if we are moving from the lamina to the another lamina, we have one window here. And this window, we will be able to peep inside the vertebral canal and we will be able to see the structures. So in order to see the structures, just I have made it very easy. Okay. So if you are seeing it because our probe is on the posterior aspect. So how we are seeing? We are seeing from the posterior to the anterior. So what do you have in the posterior? You will be having first the ligamentum flavum. Then you are going to have your epidural space. Then you are going to have your posterior dura. Ligamentum flavum and the posterior dura will be hyperechoic in nature because they are the connective tissue structures. Then you are going to have your intrathecal space and you will never be able to see this anterior dura, posterior longitudinal ligament and the posterior aspect of the vertebral body as separate structures. You will be seeing just an hyperechoic line and this line we will be calling it as anterior complex. So we have a posterior complex and we have an anterior complex. Posterior complex, if you are seeing in a very lean and thin individual, you will be able to see it very nicely. Okay, so what all do we have in the posterior complex? We have ligamentum flavum, epidural space, and then the posterior dura. So now see the structure. So this is how it will be. You have ligamentum flavum. This will be the space. This will be the posterior dura. Now this is the intrathecal space and then the anterior complex as an hyperechoic line. So this is laminar view or the lamina view, whatever you want to say. And we are going to call it as horse head view. So we have learned the finger-like projection for the transverse process and then the camel hump appearance, then the horse head appearance. And if you're going to move further over the spinous process, you will be seeing them as crescent-shaped structure. And since you can see they are lying at a depth of approximately 1.2 centimeter in this particular individual whom picture I have taken. So this volunteer of mine was very lean and thin. So you can see them at 1.2 centimeter, right? So 1.2 centimeter, only the linear probe is going to have the best axial resolution. Okay. And this, curvilinear probe will not be having such good resolution and will not be showing these two structures very beautifully the way you are able to see it with the linear probe. That's the reason if you want to look for the spinous process under ultrasound, do not go for curvilinear probe, go for linear probe. So this is again the same picture. So just a revision, anyone can unmute yourself and please tell me what is this view quickly.
Transverse process.
Very good. This is
facet.
Articular process. Okay, very good. This is
Laminar view.
Very good. This is
spinous process view.
So just remember these pictures. You don't have to remember anything. Just remember these pictures because we are tuned to all these things. So if you will remember your fingers, camel, horse, and then your moon, which is having a crescent shape, that's all. Finish. Okay. So now coming to the transverse process. So transverse process, either my probe can be over the spinous process. So either my probe will be over the spinous process or it will be in between the spinous process. So if it is over the spinous process, I am going to call it as spinous process view. If it is in between two spinous process, I am going to call it as interspinous process view. Fine. Now how they will look like under ultrasound. So if my probe is over the spinous process, then obviously I have a bone and I will be having just an posterior acoustic shadow. I will not be able to see anything. So you will not be able to see anything here. At the same time, you will be able to see the spinous process, the lamina, and then your, I should say the transverse process. In this region, you will be having your articular, I should say your superior and the inferior articular process. Okay, they are in the coronal plane when you are looking like this. You can see here, they are in the coronal planes. Okay, so this is spinous process view when you are not able to see anything. And we do call it as step ladder view. So this is one step, this is another step, and this is another step. So step ladder view for the spinous process. Then once you are going to the interspinous, you will be able to see something here. Right? Now, this will be your erector spinae group of muscles. Facet also you will be able to see very nicely in this view. Because see, if I am moving from this, I will be able to see this facet joint very nicely. And most of the time, if I'm moving from there, many of the times you will not be able to see it nicely. But this process, the interspinous space view is the best for your facet joint as well. Okay, and then you will have your transverse process. Now, this view is also very important because since it's a basic course and spine interventions are just the advanced level interventions. But the lumbar, we just call them as the intermediate level of intervention when it comes to ultrasound. So at least you can go for, I should say, the diagnostic block of the medial branch, which you will be learning, I think, the CM procedures from the next class. But for today's lecture, I will just tell you that this medial branch will be somewhere here. Okay. So you have your transverse process like this, and then the superior articular process here. And you have the medial branch, which will be just coming like this. So you can go for a diagnostic block because you have one bone here, one bone here. You're very safe. You can go for a diagnostic block of medial branch if you're having a pain which is just getting generated from the facet joint, which we'll be learning in the subsequent classes. Then how you will be counting the vertebra. This is very important. So what you can do is you when your probe is over the lamina, you keep on going down, down, down. So once your probe is over the L5 lamina, if you will go more, you will be able to see the sacrum as a straight line. Then again, you come forward, then you know, okay, you are over the L5 S1, then L4, L5, and then L3, L4. That is one way. Second is you just see the spinous process, keep on coming down until you see a straight line here, right? So this straight line will be your sacrum. So then again, you can go up, that will be your L5, S1, then your spinous process like this, and then your L4, L5. So you can follow this also, whatsoever you feel is convenient for you, right? So if you have any doubt, you can ask me, or I'll just demonstrate what we have learned. कैमरा बंद हो गया क्या माली? कैमरा आई नहीं. Just a second, let me adjust the camera. It's okay. I hope the screen is visible now. Anyone, please let me know.
Yes.
Okay. So first of all, we learn the probe position. So where you are able to see this sheet green color, okay. So that is the caudal end, and this is the cranial side. So we'll learn the probe position first. The first probe position is so if my probe, if I'm looking in the longitudinal axis like this, okay. So this is the aspect marker. If my aspect marker is in the towards his head, so I'm looking at the longitudinal axis, or I'm looking at the sagittal view, median sagittal view. The moment from the midline, if I'm shifting my probe to the lateral side, this is para-median sagittal view. But at the same time, if I'm tilting the footprint of my probe towards the midline, this is para-median sagittal oblique view. What is the importance of learning this? That also I will be sharing. Then if my probe is in short axis with the aspect marker towards the lateral side, then this probe can be over the spinous process. Then we are going to call it as the spinous process view. And if it is in between the spinous process, I'm going to call it as interspinous process view. So this is what we will be seeing. And as you can see today for the first time, in all my USD classes, I'm using this curvilinear, right? And I have set a depth at approximately 6 centimeter because my volunteer is not that obese. And this probe has got a frequency of 1 to 5. So very first thing is you can palpate your spinous process with the thumb, pulp of your thumb. You'll be able to see a bumpy thing. So approximately 2 fingers from there, you keep your probe in the craniocaudal manner. So once, let's switch on this probe. I need, oh, I have increased the depth too much. This much will be fine, I think. Okay. So the moment I'm going to keep my probe like this, right? And if I'm going to go down, you are able to see something here like this. Okay. So this we have learned. So who can tell me what is this process? We have already seen it.
Transverse process.
Yes. So this is your cranial side. This is your caudal side. You are able to see finger-like projection or the trident side. So this is transverse process view. Now what you are seeing here, this is the intertransverse complex, and this muscle is going to be your psoas, and the one which you are seeing on the top is your erector spine muscle. Okay. Now from there, I'll be moving my probe towards the medial side. Very gently I'll be moving, and you just look at the change in the echo texture of this, what you are seeing. Just notice that. Okay, so I was here. Now gently I am moving my probe, okay, towards the midline. Because the transverse process is a bigger one, okay? That's the reason you are still seeing them. Right? So they are appearing like the hump of the camel. So this is camel hump appearance. And where will you get when my probe is over the?
Articular pillars.
Yes, it is over the articular pillar. So this is camel hump appearance. So from the camel hump, if I am gonna move, again, this is transverse process. We have just, let us repeat, this is transverse process. Now we have moved, we are moving until you get something like this. Okay. Now if I'm moving, you can see the change in the echo texture of this. At this depth, I will not be able to show you the posterior view. I was trying to show you this. Okay, so this is your anterior complex. This one which you are seeing, that is the horse head view. So our probe is over the lamina. And if you see here, you are able to see one line here and one line here, right? So this is going to be your ligamentum flavum. This is your posterior dura. And the space in between these two is going to be your epidural space. Now, what you are seeing here, that is your intrathecal space. Same picture, you can get it if your probe is over the articular process and you are tilting the footprint of your probe towards the midline. So we learned about the paramedian sagittal oblique view. So let us see. Transverse process. Then this is camera. Now you see, the moment I am going to tilt, I will get the same picture, right? So that was the, I should say the importance of learning the paramedian sagittal oblique view. Now, if your probe is over the lamina, like this, let me take some jelly. So it is over the lamina. Now you keep on going, keep on going down. Okay. So are you able to see something? Are you able to see something has come? What it could be? Anyone? This is sacrum. Okay. This is your L5 lamina. It means this is your L5S1 space. This is how you count. Okay, you see the horse head, keep on going distally until you see this straight line. So this straight line is going to be your sacrum. It is no longer like a horse head. So your lamina of the lumbar region will have a typical appearance of horse head, which neither your cervical spine will have, neither your thoracic spine will have. Do remember this. This is very important. Only horse head view, you see it in the lumbar spine. And once you are moving down, you will get a flat line. Flat line means you have reached to the sacrum. Then you can just count the spaces. And the spinous process, I'll show you with the linear probe. We'll finish the spinous process view and the interspinous, and then we will go to the linear probe. So I told you that if my probe is over the spinous process, okay? So if my probe is over the spinous process, I don't know which spinous process because I have not counted. Just like that, I have put the probe. So now my probe is in the short axis, okay? Or you can say I'm looking at the axial section of the spine, right? Aspect marker is towards the lateral side and this is the medial side, okay? Now I'm able to see one and this one here, right? So this is going to be your spinous process. This will be your lamina. Somewhere here, you are going to have your, the junction, your facet joint, I should say, the junction of your inferior and the superior articular process. And this is your TP, right? Now, how to find out whether it's a spinous process or it's an interspinous? Very easy. Remember this picture. You are not able to see anything here, right? Now you see the change. And look at the facets also, which I have told you. Okay. So the moment, okay, I am somewhere here. Increasing again so that you will be able to see and reducing the depth. Okay. So now I know that my probe is in the interspinous view. Why? Because I'm able to see something here. Okay. So that is going to be your anterior complex. It will always be visible. Okay. You have to just toggle your probe a little bit because your spinous process is not just like a tip. It is a bigger one like this. So if your probe is almost once it has just leave the spinous process, then only you will be able to go inside the interspinous process, right? And see here, you have your inferior articular process, you have your superior articular process, and then this is your TP, right? And this must be your posterior dura. This must be your epidural space, and somewhere here will be your ligamentum flavum. So, and these are all your erector spinae group of muscles. So if you want to give a facet joint diagnostic block, right, you are supposed to come and from the lateral side. Okay, I'll just show you how to do it. You are going to come from the lateral side and you will hit this bone. Okay, once you are able to hit a bone, you are supposed to rotate the probe again in the longitudinal axis, and that time you should be seeing a finger like projection. Okay, means you have come in the in plane technique, and then once you are rotating your probe, your needle will be now out of plane. Okay, so you will be able to see a dot like structure, and your dot should be over the transverse process. So that is how then you inject the local, 0.2 ml is more than sufficient, because you are really seeing something and giving. And if the pain goes off, yes, the pain is from the facet joint itself. So we'll see this again. So this is our interspinous window, because oh, sorry, let me clear the drawing. Okay. Because I'm able to see the, the anterior complex. It's here, right? Now, if I have to go for a facet joint, what I will do, I'll shift my probe to this side, right? Until I see this very nicely. Fine. I'll bring my needle from here, or you can tilt it even to this also, so that you have a good view of your needle. I do it like this. Okay, I keep it in the center from here like this. Okay. Now, once you have your needle is hitting this bone, make sure it should be the bone. Don't go more deep, otherwise you will be inside the vertebral column. You will be just going inside the intervertebral foramen then. Okay, if you are going here and there. So what you are supposed to do, your needle is hitting there. Now you rotate your probe. So if you are perfect, then you will be able to see this finger-like projection, and your needle will be just an hyperechoic dot over this transverse process, right? So we came in plane like this. Okay, again I'm showing you. We were like this in plane. Okay, this is the superior facet. This one, superior articular process, and this is your inferior articular process. This is your transverse process. And how you will know that this is transverse process? We'll cast an acoustic shadow here. Okay, so this is spinous and the interspinous window. And then quickly we'll see the spinous process, how they look like. And keep practicing whenever you are giving the spinal anesthesia. You can give USG assisted. Means you identify the spinous process, the interspinous, the area, and you just start giving your lumbar. Okay, so I will now change my probe, and I'll reduce the depth also, because I don't need that much of depth. I'll go to virtual convex. Fine, right? Let me increase again a bit. So what you are seeing, exactly the one which we have seen, the crescent shape view. Now, what you are seeing here, this hyperechoic thing, is your supraspinous ligament. And if I move little down, I will be able to see another spinous process. You can just toggle your probe if you're not able to see. There is nothing, Okay, see, it has moved. So this will be your interspinous ligament position. The one which is going from the top, that is your supraspinous. So this, you can just keep on identifying like this. And you can keep on going down. See how beautifully you are able to see them. You will not be able to see such beautiful things with your linear probe. Okay. Keep on going down. Keep on going down. So now you have reached to the sacrum. Continuous line, right? So this is going to be your L5S1 space, right? If you come up, you will be able to see the spinous process. So now this is L4, L5, If I go more up, this is L4 and this space is L4, L5. This is how you can just count. So that's all in the, I think, the lumbar spine sonoanatomy. Now, if you have any doubt, you can ask me. Any doubts?
Hello, ma'am.
Okay.
For facet joint pain, if we give local ones, for how long that pain relief will be there? I mean, how many times you have to repeat?
Duration of local anesthetic?
If it is lignocaine, 20 minutes, 15 to 20 minutes.
Yes, it will be there for half an hour max. It will come back again because you have just given. What exactly do you mean by diagnostic block? Diagnostic block means your pain generator, you have just numbed that pain generator. So the patient should not be experiencing the pain, right? And there should be greater than at least 70 to 80% relief in the pain, what exactly he was experiencing. So it means whatever block, whatever like medial branches are the one they supply your facet joint. So if you have numbed the medial branches, it means now there is no sensation which is going from the facet. So patient should not be experiencing the pain, but it will be just approximately till the duration of your local anesthetic. And then you have to go for the radio frequency ablation, which usually we do by C-arm guided, and which I think the next is your lumbosacral spine. So you will be learning how to go for the radio frequency ablation of the medial branches. Okay. Diagnostic block is like you can give it with ultrasound. No need to expose yourself to so much of radiation.
Okay, ma'am. Thank you.
Okay, then if no more questions, Chinmayda, you can take your lecture.
What you're saying? You pay to Google, or you pay.
You can take your lecture. My class is over.
Okay. Just a minute. So, just. Just 5 minutes, huh? Okay. Please give me 2 minutes. I have some technical issue. I'm just trying to make it correct. Zoom. Oh. So, goal of imaging. So, whenever a patient comes to us, any pain patient, when they come to us, so first, of course, we will do the clinical examination, any physical examination and all. So, after that, we will make some differential diagnosis, and then we will go for imaging purpose, so that we can find the positive findings in support of a diagnosis. Or second thing, rule out the red flags. All patients are not for pain physicians. We cannot take all the any patient is coming with chronic pain. So there are some specific red flags, say infection, fracture, malignancy, or motor weakness. These 4 red flags always we try to see at the first setting. So first, it is the positive finding in support of a diagnosis, which we search in the imaging. Second, rule out the red flags, and third, it is the incidental finding. If we get some incidental finding, that also we have to note. So in today's class, what is included? There is X-ray, and then CT scan, and then MRI. So 3 things I will talk about. Okay. So X-ray, we are more concerned about the fluoroscopy, and but then normal X-ray, of course, we need the normal X-ray of spine, lumbar spine, or anything. So patient will come with the X-ray, but we are more always we are dealing with the fluoroscopy. So anyway, so here let us see the lumbar. Mostly it is the, say, AP view or say lateral view. We are always dealing with the AP view or lateral view of the X-ray. So here you can see, of course, this when we will start all the procedures, you will know better about this X-ray, which structure is what. So you will then better know that how to interpret the X-rays. But of course, in OPD also, while seeing the X-ray, we must try to see, we must know that which structure we are seeing. So it is a lumbar spine X-ray, you can see. So here in lumbar spine X-ray, we are seeing a 2-dimensional picture of a 3-dimensional structure. So you can see that, okay, these are the pedicles. These are the pedicles in X-rays. You can see these are the pedicles, and these in the middle, these are the spinous processes. Of course, between the pedicle and spinous process, this is the lamina. And these are the transverse processes. These are the transverse processes. So you can understand that while seeing the X-ray in this AP view, at least you can understand that which structure you are seeing. Then we will see the lateral view. In lateral view, we can understand that this is the vertebral body, and here it is the pedicle. So posterior element, all the say spinous process, transverse process, or lamina, these are posterior elements. These are connected to the body with the pedicle. So these are the structures in lateral view. So, and this is the oblique view. So this we see in a when we are doing a procedure. So in oblique view, we will talk about when actually we will be talking about all the procedures during our class. But here we are talking about the investigations during our in our OPD. In the OPD, when we advise for investigation. So in X-ray, what we will see? We will see ABCDE approach, alignment, then body of the vertebra mainly. So when we are talking about the spine, today we are talking about the lumbar spine, or say the whole spine. So alignment, body, and then cortical outline. Remember, when you are seeing, mainly it is the outline of the vertebra. We will see that all the cortical outline should be in one line. So then disc spaces and edge of the soft tissues also we can see during in the X-rays. So here you see anterior vertebral line, posterior vertebral line, and this is, of course, spinolaminal line is not important here in OPD. It is important during the procedure for certain procedures, and this is the posterior spinous line. So as soon as you see a X-ray in the AP view or or in the lateral view, you will see, you will make a line in your mind that all the anterior vertebral line can be made or not. All the vertebrae are maintaining the alignment or not. And then posterior vertebral line also, you will see that whether they are aligned or not. Okay. So these are this shows the alignment. There are multiple measurements, but of course we are not going to do all the measurements. By different measurements, whether it is a lumbar spine or it is a cervical spine or it is a thoracic spine, we can understand that whether the normal lordosis where we can find lumbar and cervical level, or normal kyphosis which we can find in the thoracic level, that is normal or more or less. So this alignment we can understand. So when we are seeing the in OPD, first we will see that these lines are very important. The anterior vertebral lines and posterior vertebral line and spinous, posterior spinous line we will see, and then we will see that whether the normal kyphosis or lordosis is normal or abnormal. Okay. So here you can see in a lumbar spine, that is left side, we can see this is hyperlordosis. It is too much lordotic. Okay, though the anterior vertebral line and posterior vertebral line is in a normal position, so there is no movement between the vertebrae, no listhesis, but there is hyperlordosis. Then middle one is hypolordosis. Okay, and this one is basically lower part is nearly normal, but upper part is becoming the kyphotic. Okay, so in one spine you can see both the lordosis and kyphosis also. So this type of alignment disorders, here there is no normal spine. Okay, so here all are different type of alignment disorders. So you should see immediately that whether it is these alignment disorders you can see or not. This is also same thing in the cervical spine also. You can see that these alignment disorders are there or not. So lordosis, straight, kyphosis, sigmoid, as the last one I told you, that in one spine only one part, lower part is lordotic, upper part is kyphotic. So this is called sigmoid. Okay, alignment abnormality. So it applies for in all the areas of the spine. Next comes scoliosis. So scoliosis also can be seen in different areas. Most of the time it is seen in the thoracic area, but in the lumbar areas also scoliosis is possible. Of course, there are methods to calculate or to measure that how much scoliosis is there, less or more, whatever. But then this scoliosis that is not much needed when you are seeing in a OPD, that you don't have to measure that much scoliosis, but you should note that if there is scoliosis or not. Okay, so then comes, so this is the alignment first, ABCDE approach. We talked about the alignment just as soon as you see a X-ray in the OPD. Then comes body. So what you see in the body, there multiple things can happen in AP and lateral view. Firstly, it is the fracture, and secondly it is the degenerative changes. Some degenerative changes can be there in the body, and fracture also we can see. So what are the main degenerative changes? Okay, first we talk about the fracture. So fracture also, there are multiple types of fracture can be there. So you can understand as we talk about the fracture, it is one of the red flag. So when it is why we are talking about that, because only one type of fracture is there which we pain physicians treat. Like say here there is compression fracture, burst fracture, flexion distraction, fractured dislocation. So all these three type of fractures we will not treat. Of course, these three type of fractures mainly are for spine surgeon, orthopedician, neurosurgeon, whatever, though it is for spine surgeon, orthopedician. So here these fractures, but the compression fracture mainly it is the osteoporotic compression fractures we treat as a pain physician. So we will see that whether this is fracture is there or not. Here you can see fracture are also different type. These are all osteoporotic type of fracture. I told you that there are 4 types of fracture we can see, but these 3 are not our cup of tea. We are mainly concerned about the compression fracture. Now compression fracture, osteoporotic compression fracture, can be different type, not trauma related. So can be different types. So wedge fracture, biconcave fracture, and again the crush fracture. So mainly we are concerned about the wedge fracture and biconcave fracture. These two fractures in osteoporotic type of compression fracture, we as a pain physician mainly treat. Okay, and that can be of course mild, moderate, severe. So we treat all the types if it is wedge fracture or biconcave fracture. So in body part, we will see if there is a fracture or not. Then you can see different type of fracture. As I told you, wedge fracture, it is the this is compression fracture but wedge fracture, and this is compression fracture but biconcave fracture. Okay, so this is of course the posterior side, it is the compression fracture, and here it is called vertebra plana. So there hardly any body is there. So in those cases, we sometimes of course we can do, but it is better to send to the surgeon. Degenerative changes of the spine. So as I told, in body part, two things: one, fracture; second thing, degenerative changes. So what are the degenerative changes? As soon as we see this type of spar of bone, so we know that these are degenerative changes, osteophytes. These are called osteophytes. So by seeing all the osteophytes, these are osteophytes. Okay, there's this perpendicular lines. Remember, these are perpendicular lines and not going from one bone to another bone. This is perpendicular bony spars. So this is one thing. Second thing is narrowing of disc. You can see the disc space is narrowed. So commonly it is affected in the cervical or lumbar spine, and we see osteophytes, end plate irregularity or sclerosis. Here you can see many these areas are end plate. Here you can see these are irregular, end plate irregularity. Okay, end plate irregularity is there. Vertebral osteophyte already you have seen. Disc place narrowing you can see, and vacuum phenomena. What is vacuum phenomena? You can see some air inside the disc part. So this is the disc part. Here you can see this black shadow, this completely black shadow. This is the air. So these all are indicative of degenerative changes. Degenerative. Okay. So A and B is seen. So this is the vacuum phenomena. Vacuum phenomena. Vacuum phenomena. Okay. So whenever we are seeing the lumbar spine, we will see these two things. And as I told you, that fracture can occur, compression fracture. The most common cause of this compression fracture is osteoporosis, and we may see these type of picture when it is very difficult to understand that which structure is what, which structure you are seeing. It may become very difficult because these are very thin structures. Then remember, only we can understand this is lateral view. This is lateral view, and we can see this is biconcave fracture. This is biconcave fracture. This is also looks like biconcave only. And in the AP view, whatever, no matter how much osteoporosis is there, one structure is always visible. 99% cases. What is that? That is the pedicle. That is the pedicle. As soon as you find the pedicle, you can understand all of the structures. Like between two pedicle, it must be the spinous process. Okay, between spinous process and pedicle, it must be the lamina. And then, of course, behind all the pedicle, this is the area for body. Then, so in that way, so these are osteoporotic spine. Now, as I told you, cortical outline. So anterior vertebral line, posterior vertebral line we will see, and when we will see the spinous line, that is also normal, but in this case. But you can, of course, here in posterior vertebral line, you can see that there is a up and down. Of course, here in anterior vertebral line also, this slipping of vertebra is there, one vertebra above. But mainly cortical outlines, and outline means it is not only the anterior posterior vertebral line and spinous line. You should see all the margins of the different structures. Okay, because the spinous process, this also there can be a chip fracture in the spine only. So or say there can be a chip fracture in some other part. So there will not be a gross dislocation, but that small chip fracture also will make a cortical break. So these cortical is also to be seen. So here you can see in oblique part. So this area, this is a Scotty dog view, oblique view. So this area, it is a very regular, but here there is a break. So this break is called spondylolysis, and this, due to this spondylolysis, slippage occurs. One bone is slipped anteriorly over the other bone. Okay, so maybe this is the L5 over S1. This can maybe a lumbarized sacrum. Okay, so here this slipping is called this is the enterolisthesis. Okay, this is called enterolisthesis. So there can be this cortical outline break is there or not, that also you must see. So this is part C. So when we see a case of spondylolysis or spondylolisthesis, then that also can be grading can be done. Okay, so here you can see 5 grades are there of Mayarding classification. So this classification is how much slippage has occurred. So this gives us the severity. And remember, if there is too much slippage and patient is complaining of radicular pain and all, so in those cases it is not our case. We must send the patient to surgeon, because we cannot realign the anatomical dearrangement. Okay, so this is not possible. Syndesmophyte versus osteophytes. Remember, I showed you the osteophytes. So these are osteophytes, okay, which is the perpendicular projection from the bony ending. But here you see these are not perpendicular. These are going from one bone to another bone, one bone to another bone. So these are called syndesmophytes. So syndesmophytes and osteophytes. So these are called syndesmophytes. Okay. So so the syndesmophyte is a different disease altogether. Whenever you are seeing the osteophyte, you know it's a degenerative process. Okay, maybe due to the age only, it is a degenerative process. But as soon as you see the syndesmophyte, you must be very much cautious that it is not a degenerative process. It is a inflammatory process. This patient can have spondyloarthropathy, like ankylosing spondylitis is a very popular, not popular, I say well-known disease. So it can be a case of, this is Bembo spine. It's a case, maybe a case of ankylosing spondylitis. So as soon as you see the syndesmophytes, then you can you have to treat in a different way. It is not only the pain, it is the background reason of the pain, that is inflammation. Okay, systemic inflammation. So that treatment also you have to do. Of course, you can take help from the rheumatologist also, though we also do this treatment. Now, as I told you, that spinous process, this spinous process line is also important. But then, as I told you, the cortical outline, when you are seeing, so it is not that only the margins, but the all separate bony margins are also important. Here you can see one all the spinous process should have some gap. Okay, that is the normal anatomy. But in some patients, one spinous process may hit another spinous process. Okay, these are called kissing spine. So these can also be a cause of local back pain. So you have to, while seeing the x-ray, you have to take note that whether if it is the localized pain is there, you must see that this spinous process also is touching one another or not. Here you can see a small fracture in the spine. So here you if you do not note here, you will be saying that okay, all alignments are correct, or everything is lines are all in the normal line, normally aligned. Alignment is really normal. This small fracture has not changed the alignment, but still this fracture can cause a continuous pain. But of course, this will not be treated by us. Transverse, even the transverse process can have a small fracture. So when you are seeing the epiview, it is not the different structures only, scoliosis also you will see, but the different bones also you will see if there is any fracture. While evaluating the lumbars, back pain, lumbosacral spine, when you are evaluating SI joint also, you must take a take a note. You should see the SI joint also. So you should see most of the back pain. If it is a lower back pain, SI joint pain also can cause the similar type of back pain. Sometimes becomes difficult to identify that if pain generator is in the spine or in the SI joint. So you always in APView X-ray, you evaluate the SI joint. Here you can see clear margins of the SI joint. So when you will see SI joint, you see the margins of the bone, margins of the sacrum and margins of the ilium. So it is very clear lines. But you see it is not clear. It is hazy. It is hazy. And second one, this one is completely dearranged. I mean, there is edema also, and it is completely dearranged. And this one is grade 4 actually. So this one is completely ankylosed. This is completely ankylosed. You cannot see a joint line. Actually, this one is also not normal. This one is actually normal. This one is grade 1. Okay, subtle blooding. This is grade 1. This one is normal. And this is grade 2, grade 3, grade 4. So while you can at least for seeing, at least when you are seeing the X-ray, you must see the margins, and you should see that whether it looks completely normal and clearly identifiable. That is okay. And if it is not, you know that there is some arthropathy. There are some post-surgical changes. So in patient comes to you with back pain, many times they are operated. So you see that surgeon has taken out the middle part of the spinous process with laminas. Okay, so you must note that what surgery has been done, whether lamina has been taken out, spinous process has been taken out, or it is a small punch only. Here you can see all the spinous process and laminas are taken out. Okay, so this part is black, and these are fixed with different screws. These are called pedicular screws. So they have fixed it. So these parts you must know. Why you must know? Because they not only gives you the I mean helps in diagnosing. Another thing is, if you plan for a procedure, you must know where is the screw. You can sometimes, for due to the screws, some procedures become more or less impossible. So if you plan, you take the patient on the OT and the OT bed, and then you cannot do that procedure. So it is better to anticipate the things prior. So you see the X-ray and note these things. Okay, some things are congenital variations. So here you see small transverse process of L5, but here it is a big transverse process. So this is called Bartolotti syndrome, that these transverse process and sacrum, ala of sacrum, so they are actually hitting each other. Okay, so it can cause a small arthritis, and gradually, I mean, it is not that patient is developed suddenly, it is there since birth, but suddenly it starts causing pain, it starts causing hitting each other. So this is a Bartolotti syndrome. So this may be also a cause of pain. Okay, so and see, sometimes if you see a AP X-ray, so there it is a spina bifida. So these are not cause of pain, these are normal for that patient, congenital variation. Okay. Sometimes you may see a very long lumbar spine. So there must be a lumbarization. That's why it is long lumbar spine. Sometimes you may see it is a short lumbar spine. So there may be a sacralization. So this is a short lumbar spine. So these things, these varieties, these things are there. Okay. Just a minute, Dr. Deji. Okay, so these are hemivertebrates and all. So these congenital variations also can be there. So now fourth and fifth is ABCD approach, disc space and age of soft tissue. So disc space, already I told you that vacuum phenomena, or it is I mean small disc space loss, I mean reduction of the space. That is the most immediate usual finding in a case of degenerative spine. And this one, your if it is a soft tissue, as I told you, the age of soft tissue is more important if it is an injury. Otherwise, we do not need. Now, next is CT scan. So CT scan, it is always very similar to X-ray. Both are X-ray only. So it is more or less similar only, but it is a cross-sectional image. It gives a cross-sectional image, and mainly bones are visible. You can understand that we see the bone only, since it is X-ray. But other structures are also seen, but not in that in that clarity by which we can see the in MRI. So useful where MRI can't be done. When in some patient you want to get an MRI done, but if it is cannot be done due to say implant, patient is claustrophobic, patient do not want to go inside the machine, MRI machine, so you have to write the CT. So whatever is seen, I mean, at least you have to accept that. Specific instances, it is best or better than other modalities, even MRI sometimes. Very little, I mean, very less indications. Say there is a small osteophyte in the foramen. Osteophyte is made of bone, and that small osteophyte may be seen better in CT than MRI. Okay, CT myelogram can be done if MRI is not indicated or MRI cannot be done. Of course, MRI also have a option of doing myelogram, but then earlier it was too much preferred. So in MRI, as I told you, so these are all sections in different planes. Either it is axial section, sagittal section. We are seeing. So here you can see a small chip fracture, one small chip fracture, small chip osteophyte actually in the foramen area, that is very nicely seen with CT scan. In SI joint area also we can see very nicely with CT scan, different articular aberrations and all we can see. Okay, in myelogram also, earlier it was used to be done to diagnose a lumbar canal stenosis. Okay, lumbar canal stenosis. So we can see that myelogram will show you this type of picture. This is called beaten apple appearance. Beaten apple. So this white part is the contrast in the CSF. Contrast in the CSF, and then it is compressed from both the sides. From this side, it is from anterior side, it is the disc is compressing the canal, and from posterior side, it is the ligamentum flavum is compressing the canal. So this is called beaten apple appearance. So nowadays it is not needed. We are going for MRI. So a few things you must know about MRI. As a pain physician, MRI is the gold standard thing in today's world. We always see the MRI for back pain. So understand what MRI does. So MRI is also we are seeing like a cross section or sagittal section or coronal section, different sections. We are making sections. Okay, so sections, not the whole patient, but the important area where we want to understand that area. So in that area we are taking sections. So you can see here, of course, to interpret an MRI you must know the planning. This planning part is done by the radio technician. You see the lumbar spine area. It is not that the whole spine has been actually is seen. It is only the area which is important, not the whole spine. See the disc space area. Only the disc space area has been scanned. Okay, MRI scanning has been done. Only the disc space area, not the lower sacrum part and all. Okay, so only this part, and here numbering will be done. Okay, so 1, 2, 3, 4, 5, 6, 7, 8, like that numbering will be done, because you may not be able to distinguish that this upper one and this lower one, they may look like similar only. So from the numbering you can know that, okay, and by seeing the planning and numbering, planning is also printed on the MRI plate. Okay, so by seeing the planning, you can know that okay, this part is showing this picture, and that is very important for interpretation. And I mean, planning is done in sagittal section also, axial section also, coronal section also. Everywhere this planning is done, and then only you can see the picture and can say that okay, which area I am seeing. Otherwise, we are bilaterally symmetrical human beings, so a right picture or left picture, it is if it is taken in the same area, it will give the same picture. Okay, so it demonstrates the soft tissue also, and MRI has a big advantage. What the advantage is, it can rule out inflammation. Like it is not only the anatomical derangement it is saying, that is told by other like CT scan also, but it is telling you the physiological change also, like immediate acute inflammation is there or not. Okay, if there is a acute inflammation and there is bony edema and all, it will show. So this is a great you can see you can say this is a great adjunct for our diagnosis, like sacroiliitis and sacroiliac joint arthropathy, or just degenerative destruction of the joint is two different things and requires two different type of treatment. So it can rule out inflammation and it demonstrates the soft tissues also. Okay, now this part everyone should be very attentive and remember because this is we need every day. So remember, three planes of imaging. As I told you, this is the upper part, this is the planning. So this is sagittal section, this is axial section, and this is coronal sections. Coronal section most of the time is not that important for us, or maybe it is important for radiologists when they are seeing the lumbar plexus and all, then it is important. But for us, mainly the sagittal and axial section. There are planes versus sequences. So what is that? Planes means these are the planes, sagittal plane and axial plane, these are the planes. What is sequence? Sequence means seeing the same picture in a different color planning. So this girl's picture, you can see different color planning, but it is the same girl only. So you remember basic sequences T1 and T2. So it is a digital change, you can say, digital planning, where fat becomes white in T1 and in T2 water becomes white. So simple thing. You will see the same structure but with this planning, with this coding. So in first picture, fat becomes white, and in T2 sequence, water becomes white. Finish. White, of course, white is not a medical term. I am at present telling you just to make you understand. Modified sequences, and one modified sequence we always use, that is called STIR. That is all different types of modification can be done, like suppression or enhancement of what? Of either fat or water. You enhance the fat or you suppress the fat. You enhance the water or you suppress the water. So these things can be done. But we are mostly, what we are doing, we are using the STIR sequence. What is STIR? In this sequence, fat is suppressed. Simply, fat is suppressed. Remember, T2 STIR, here fat will be suppressed. Mainly what we use during our evaluation of MRI. So remember, what are we looking for? Anatomy. First thing, in T1 and T2 sequence, we will look for anatomy. But whether it is inflammation or infection, of course, it will not show you the bacteria. So, of course, inflammation we will see. Mainly what happens in inflammation or infection, there is edema, water collection. Okay, so in some area which is infected or inflamed, there should not have been any water in normal patient, but we will see a water. So that part we will see in STIR sequence. So these three sequences are always used most of the time. Now, as I told you, I told you white or black, but in medical term, white means hyper intense. So here in MRI, when we are talking about MRI, we will talk with intensity, hyperintense, isointense, hypointense. Here isointense means same color hue. Okay, hypointense means related to someone. A is hypointense than B. So B is more black, more white, and A is a bit blackish. So it is hypointense. But A is more hyperintense than B means A is more white. More white means hyperintense. Okay. So this is the medical term. You know, in ultrasound it is hyperechoic, isoechoic, hypoechoic. So same thing. So here you remember. So we are talking about this is a sagittal section. Let us talk about a sagittal section. So in sagittal section, T1, T2, STIR. Here, see, this one is T1. This one is T1. So, and this one is T2. This one is T2, and third one is STIR. So what we expect? We expect in first T1, it is the fat which is white. I already told you, just memorize this part. This is very important. T1 fat white, T2 water white. Okay. So this is the, so remember, fat to water journey. T1, T2, STIR. T1 fat white. T2 is fat plus water white. Okay. And STIR means, I told you that water here fat is suppressed. So here only water is white. Okay. So T1 fat white, T2 fat plus water white, and STIR is only water white. Remember, this I told you. Water white means fat plus water. I mean, fat is already white and T2 fat plus water. So this one you remember. Okay. So now this is sagittal section. Let us see the this one, axial section. So here also same thing. T1 fat white, T2 fat plus water white, and STIR sequence, though it is not the same area, but STIR sequence, it is only the your water is white because fat is suppressed. So let us see a sagittal section and one cross section, axial section. Now I will annotate few things so that you can understand better. So what are the things we are seeing actually? Where is that annotation? Okay. So okay. So this is the sagittal section. Okay. So what we see here, first say from posterior side, this area, what is this? This is the fat area. This is the fat area. Okay. Now after the fat, so skin is also here, but skin hardly we can see, or it is not needed also. So this is fat area. So after that, what we are seeing? So this area is the spinous process area. These are the spinous process. Okay. So these are the spinous process we are seeing. Okay. Now let us see between the spinous process what you will see. You will see the interspinous ligament. This is supraspinous ligament, and this part is interspinous ligament. Okay. This is supraspinous ligament, and this part is interspinous ligament. Okay. So clear drawing. Okay. So now this in between area. What is this in between area? What is this in between area? So this in between area, this part is the spinal canal. Okay. So in spinal canal, we can see this area. This area is white. This area is white. So what are these areas? These are the epidural fat. These are the epidural fat area. Okay. These are the epidural fat. Now comes ligamentum flavum. This black line is the ligamentum flavum. This black line. This is the ligamentum flavum. This is the PLL. Here it is normal, so you can see only a black line. only a black line. This is PLL means posterior longitudinal ligament. Okay, only a black line. It can also become thicker in a degenerative spine. These are the body of the vertebra. These are the body of the vertebra. What is this part? This is disc. You can see this disc in the periphery, it is black. In the middle part, it is white. Why? In the periphery, it is the annulus fibrosus. In the middle part, it is the nucleus pulposus. Nucleus pulposus and annulus fibrosus. And then, of course, it is the ALL. Okay. So this is the sagittal section. This is the sagittal section. Here, some other things let us see. As a pain physician, if we are thinking that from spine pain is coming, then as I told you, ABCD approach is there. Apart from that, what we are seeing here, just okay, let us count. So this is 5, 4, 3, 2, 1. Okay, I think it is the S1 actually. So it is 5, 4, 3, 2, 1. Okay, so because we can see that in sacrum it is 5 elements are not there, only 4. So that's why. So anyway, so here we can see that up to this much is the at L1 level. We can see that at one level our spinal cord ends. So this is the ending of the spinal cord. Okay, so this part mainly, it is the ending of the spinal cord. From here, after this upper part is the cord, but after that, the fibers of coda equina fibers you will find. It is the midline. Okay, it is the midline picture, midline sagittal section. That's why these fibers you cannot see much. Only this way small fibers are there. So these are coda equina fibers, and this is the area where the spinal cord ends. So this is the ending of spinal cord, and these fibers are coda equina fibers. Okay. Now, this is of course CSF. This is CSF. You can see. Now, here in sagittal section, by seeing that this spinous process, we can see that this sagittal section has been taken in the midline. Okay, means it has been taken here. Oh, I cannot draw clearly. Okay, so it has been taken here. So how it will look like when it will be taken here or here or here, like this. So in those cases, the sagittal section, how it can be. So that we will talk later. First, you see, as I told you, this is fat, this is white, and this is CSF. This is CSF area, but this is also white. So someone tell me, what sequence should it be?
T2.
T2. Yes, because fat plus water both white. Now, so here let us see what we can see in a this type of section, axial section. So here also first see the structures. Okay, what we can see. So here we can very clearly see that this is the vertebral body. This is the vertebral body. Here we can see this is the spinous process. This is the spinous process. This is the facet joint area. This is the facet joint area. So now see one thing. This hypoechoic area and this not hypoechoic, hypointense. This hypointense area, I mean like this gray color, and here it is black color. So you can understand this part, this tissue and this tissue is not same. One is less black, one is more black. So what it can be? It can be disc. Only otherwise, if it would have been a bone, then this color and this color will be same. But it is not same. So you understand that this is disc. And this part is annulus fibrosus. And this part is nucleus pulposus. As we can see, this white part and this white part is same. Okay, so this is the cross section has been taken through the disc. So when you take a cross section through the disc here, like in this area, then you can see the foramens also. Here it is the foramen. Why I am saying it is the foramen? Because there is no connection between these two. Otherwise, it would have been a pedicle area, and you would have seen a bony connection between this and this. Okay, so it is between the pedicles. You can see axial section between the pedicles. Now concentrate in this area. In this area, it is the facet joint. Okay, so facet joint is made by two bones. One bone comes in the lateral side, and one bone be there in the medial side. So what is there in the lateral side? Lateral side is always the SAP, superior articular process. Remember, it is always the lower one is holding the upper one. So it is laterally, and upper one is medially when making the facet joint. Okay, so this is the SAP of the lower vertebra, means superior articular process of the lower vertebra, and the medial one is inferior articular process of the upper vertebra. So our target, mainly we will see the facet joints, whether it looks like normal both side or there is some degenerative changes. Already you know that how it looks at degenerative change, simple osteophytes or irregular margin. Maybe it is not, whatever you see in SI joint, you can see here also margin irregular. And this beautiful white line will not be there. It is complete irregularity, maybe too much of fluid, or you will see that is not normal. So you will see the composition of SI joint also. And what we can see, of course, these are the muscles, these areas. Okay, so these are the erector spinae muscles, erector spinae. These are the psoas muscle, this much psoas muscle, and this small leaf-like muscle. This small leaf-like muscle is called quadratus lumborum. So these are muscles. Now let us see this area. You can see this is completely white. So what is that? This is the CSF. This is the CSF, white area. You can see this area also, this triangle. These are both are white, but both are not same. One is, this is fat, epidural fat, epidural fat. And as you can see, this area in the sagittal section, these two areas are more or less in the same line only, in the same area only. Only ligamentum flavum is there, but you cannot see in this picture. So here actually ligamentum flavum, it is maybe a bit lateral picture. That's why we are seeing the ligamentum flavum in this way. But here, if you see that ligamentum flavum is here, this is ligamentum flavum, this is ligamentum flavum. So if you take a direct section through bone, ligamentum flavum should not come. So maybe this is a picture sagittal section going through like this. That's why this ligamentum flavum small came. Okay. Now, this is epidural fat. This part is epidural fat, and this is the CSF. Okay. Now, what are these things? These, small dots. So these are the coda equina roots. Coda equina roots hanging in the CSF. Now, remember, since our sacrum foramens are all posteriorly placed. Okay, so these roots are sacral roots, and since the lumbar roots are sidewise placed, so these roots are lumbar roots. Okay, so from the very when you are taking the cross section, you will see the roots are in a differently located. But of course, here some lumbar roots also may be there, but it will be at the side, and gradually it will come in the foramen like this and will come out. but sacral roots will go posteriorly because sacral foramens are posteriorly. Now, this thing is normal, this concavity, okay. But in lumbar spine, it is in say L5. This section may be at the L3 level like that. But if it is in the lower area, then it is always possible that this concavity is not there. But if concavity is not there, immediately you should not jump to say that it is very much abnormal. No, lower spine L5S1 or disc base L5S1 or L4-5, it is possible. Okay, this concavity is not there. But then okay, these are the roots, okay. These are the roots, these white, these are the roots. It is not only the roots which this root will ultimately go inside the psoas, okay, making the lumbar plexus. And here some posterior, we know the dorsal roots, no? So this is the dorsal root coming out, but we cannot see the whole nerve here. So these are ultimately, these are the roots. Okay. So inside the CSF, these black dots, and outside it is hypoechoic or white color. Okay. So these are the roots mainly. Okay, now, so CSF is white here also. CSF is white, and no, this is fat okay. So this is fat and this is white, and CSF, this is also white. So this is also a T2 sequence, but plane is axial plane. And here it is T2 sequence and plane is sagittal plane. Okay, so let us see the next slide now. Okay, so here I just told you that when you see a sagittal plane, immediately how will you understand that in which area sagittal plane has been taken? It can be right foramen, it can be left foramen, it can be lamina, it can be in the middle spine, spinous process and all, everything it can be there. So one way is to see the sequence planning, that is okay, but still with planning you can know, but otherwise also you should go, think for other differences which tells you that where you are. So you can see here there is a bony joint, a bony connect. You can see that from the posterior element, this is the posterior element and this is the anterior body. So both the structures are connected. So you know that this sagittal section is going through the pedicle, That's why bony connect is there. Of course, is this part it is not there, but still it is nearly body, pedicle only, pedicle level. Okay, here this is the foramen level. This is at the foramen. You can see clearly this is the foramen. And when you see the foramen, then you know you cannot see any spinous process here. Okay, this is the foramen level. This is the pedicle level or articular process. You can see this is the superior articular or inferior articular process. So you know that you are just in these areas, you are just medial to the pedicle, so that you are just on the superior articular or inferior articular process. By seeing the bone, it is the midline. You can see clearly the spinous processes. So you are at the midline. But here you can see the spinous processes are not spinous processes, also not coming and joining over each other also. So what it can be? Somebody tell me, what is this? Any idea? You can see bone pieces like this. I am audible, no? Okay. Hello?
Yes,
yeah, audible, no? Okay.
yes, sir.
Okay. So what it can be? Pyramidian spinal, when you give, you need some space, isn't it? So these are laminas. So this is a sagittal section in the laminal level. Okay, this is again foraminal level. So you starting from one side, from say left side to right side. So this which one is left and which one is right, though in planning, I mean, it is printed like this, that from left to right. but you can see both foraminal level when it looks similar, then you have to see the planning. So say this is the sagittal image, sagittal section, but which sequence? This you can see the fat is white and CSF is black. So it is T1. T1 sequence sagittal planning. Now sagittal section, but T2. So CSF is white and fat is white. Otherwise, all the same. It is at foraminal level. It is at the yes. This is just beside the spinous process. This is midline. This is lamina, and this is foramen. So now let us see the axial section T2. So you can see fat is white. This one is white. Your CSF, and you can see there is no connection. So this is the foraminal level at the disc level. Okay, this is the disc. Okay, bony color is different, disc color is different. But here both the colors are similar. I mean, it will most of the time it is similar, and it is the connection. So this connection is nothing but the pedicle. So it is at the vertebral body pedicle level. Okay, so by seeing the cross section, you can know that what you are seeing. And here it is T2, you can understand. So let us see a T1 structure again. So you can see the fat is white, but CSF is black. CSF is black because in CSF area, it should have been like this. Some black dots in the all white CSF, but it is the complete black like this. So what is this? This is a T1 sequence axial section. Okay, so this much. And disc herniation and all these are always seen by both the sections. Either it is axial or it is sagittal. They are different type of disc herniation is there that we are not talking about at present. These are prolapse, extrusion, sequestration. These are theoretical parts. But only when you are seeing a cross section, you must know that it can be this disc prolapse. So you can see that this is the disc. It should have been like that. Annotate. Okay, it should have been like that. Okay, if not, if this notch is not that much, then also it should not have protruded. It should not have protruded. Okay. What is happening? Okay, then also it could have gone like this, but it should not protrude like this. So you know this is a disc herniation. So disc herniation, this is central type. This is central type because it is the central position, and you can see this is in sagittal section also. You can see this disc herniation. But remember, as this is the central type, your sagittal section also should be a central. I mean, it should go in the midline. So it is the spinous processes you can see. So in this sagittal section, you will see this one, not a foraminal sagittal section. Okay. Okay. Next one, this is the paracentral type. So you can understand that this is not in the midline. It is at the one side. So this is the paracentral. So this, remember in MRI, this picture, this side is right. Your left is MRI is right. Like patient is lying supine and they are taking the cross section. So this side is liver side, you can say. So this is right side. So this side, right sided paracentral type herniation. This is left sided paracentral type herniation. Here one more thing you see. Here at this area, this consistency and this consistency color wise is same. Color hue is same. That means what? It is at the level of the disc. Okay, but is it same? This color and this color it is not same. Means this is the vertebra, and you can see pedicle connection also. But still you see the black disc. That means what? the above level or rarely lower level also, disc came out and migrated. Okay, so this is migrated disc. Now let us see the foraminal disc. So foraminal disc is just when the pedicle is not there, so just be below the pedicle, as that area where pedicle should have been. So if there is a disc in this area, this is called foraminal disc. So here you have to understand this sagittal section has to be at the foraminal level. Otherwise, how you will see? So at the foraminal level, you can see. Actually, this is the area, but it is not very clear. But then it's okay. In the sagittal section, in the foraminal area only, you can see that foraminal disc, and here you can see in the axial section. It is the foraminal disc. Okay. Next one is, so extraforaminal disc is very uncommon, but it can happen. So this is the extraforaminal, means complete foramen is it is outside the foramen. So this is the extraforaminal disc, and sometimes it is not not giving pressure to the exiting nerve root here, but the exiting nerve root from upper level. Okay, so it can happen. So here this is the your extraforaminal disc. Like what has happened is, if this is the complete margin of the disc, the posterior margin is not the it has not protruded through the posterior margin. It has protruded through lateral side, and it is so much lateral that it has gone outside the foramen. Okay, so this type of disc protrusion can be there just by seeing the MRI. You can see, and later. So lumbar canal stenosis is another type of finding. Here you can see it is only disc and disc, the whole central canal, there is no CSF. So this is called lumbar canal stenosis. So whole area has been eaten up by the disc fragment, and actually the roots, all the roots are there. It has to be there, otherwise where it will go. It is there, but it is completely compressed, and this white part is the epidural fat, what you are seeing. So in these cases, say you can see here that central, this sagittal section is central. So here you can see that it is completely compressed. These are the coda equina roots. These are the coda equina roots. So in these cases, of course, maybe many times surgery is needed. Only our intervention is not sufficient. Okay, one thing I did not show you, coda equina roots. Okay, here. So you can see as I told you, this is the midline. Coda equina roots may not be seen clearly here, but when you see a bit at the side, then you can see the coda equina roots. Here the pictures are a bit smaller, but in the paramedian area, coda equina roots are better seen. Okay, because roots have is traversing. It is going from midline to the foramen. It has to go out through the foramen, so you can see in the paramedian area also nicely. So okay, one more important thing. Okay, lumbar canal stenosis I talked about. This is the lumbar canal stenosis, and so lumbar canal stenosis. Otherwise, this canal is compressed. Here, the canal is compressed by the disc, but the canal will get compressed by if the bone is moving. So this bone has come anterolisthesis. It has come a bit forward, and this bone is backward. Not backward. This bone is in the same place, but upper one has come forward. So here, I mean, it is the bony fragment and all, everything has made the spinal canal compressed. Okay, so this is a different case. So here you can see that this area looks like bony and this area looks like disc. Okay, so in these cases, sometimes it happens that when in one section only, you will see, say one section is taken like this. Yeah, okay, I cannot draw in that way, but some part of the bone is also seen, disc is also seen like that. So in those cases also it is listhesis and canal stenosis. Symptom will be same, but treatment will be by the surgeons here. So all types of lumbar canal stenosis a bit difficult to treat by our intervention. Here ligamentum, here also another type of lumbar canal stenosis, but here you see nicely disc is there, no problem, but still there is no canal. Why it is like that? Because the posterior, from posterior part, it is the ligamentum flavum hypertrophy. Ligamentum flavum has so become so big that it is not the spine, the spinal canal you cannot see. You can see here also axial section, the ligamentum flavum is there. This is the ligamentum flavum, but it is not hypertrophied. Okay, but it can happen that very rare that only ligamentum flavum is hypertrophied. Most of the time it is anteriorly by the disc and posteriorly by the ligamentum flavum. Ultimately this canal is compressed. Okay, so as I told you, MRI will show you the anatomical change, but this is one benefit of MRI. Second benefit, what is that? That is, it shows the inflammatory changes. So it can show inflammatory changes at anywhere. Say, as I told you, osteomyelitis, it is the bony edema, infection edema, or say simple metastasis of a bone. So there also edema will be there. So it shows those areas and tells you that okay, edema is there, means either inflammation or infection. One thing will be there. But for us, one more important thing is modic changes. What is the modic changes? So it is a remember, modic change means disc degeneration stages. You can say disc degeneration stages is staged by modic changes. So type 1 means edema, type 2 means fat, type 3 means sclerosis. So fat and sclerosis both are degenerative, means age related, and we cannot do anything for this background thing. But type 1 is edema. Type 1 can be a inflammation or infection. So if type 1 is there, then you have to be a bit cautious. You have to be a bit cautious. So in MRI, in type 1, type 2 and type 3, so what you will see? So you will see, so here this left side is actually T1 and right side is T2. Okay, sequence. You will just match the same area in both the sequence. In type 1, if it is black and same area is white, then you suspect edema. So this is the only important, that you are suspecting edema. You have to rule out that there is no subtle inflammation. You have to rule out by history and all, everything. If it is going on and on, gradually increasing, and patient is not getting better, you have to think in that way. But what is type 2? Type 2 means both are white. So in T1 also this is white, in T2 also this is white. What is white here is actually the end plate changes. Okay, not the disc, end plate. Edema will be at the end plate. So see the focus at the end plate. Here it is clearly white. It is a bit unclearly white, not that much. But if it is both white and plate, then you will say it is modic type 2, means there is fat deposition. So it is degeneration. You will not think. But type 3 means all black. What is that? All black. End plate changes. So this means sclerosis. So sclerosis is also a type of degeneration. Bone becomes fibrous tissue, and this is also a type of degeneration. So in either they should be white or they both the same area in T1, T2 should be black. No problem. But if it is one side white is one side black in T1 and right side is white, then you have to think of a edema, and edema can be infectious in some cases. So you have to think about that. Okay. So this modic changes we understood. Now, small snode is most of the time not painful. So what is small snode? Small snode is these are all small snode. Means these are small snode. Most of the time you don't have to do anything. It is a degenerative thing. So disc, there is no hard and fast that disc will come posteriorly and anterior, I mean sidewise. Anteriorly it doesn't go, but mainly posteriorly. It can go through and through the end plate of the upper vertebra or lower vertebra even. So if it will go to the lower vertebra maybe. So if it punctures the your end plate and goes through and through upper vertebra or lower vertebra, so this is called small snode. In general, it is not painful. You don't have to do anything, but it can become painful in some cases. Today only one patient came to me that localized pain, good amount of moderate amount of pain going for 7 years, and it radiates to both sides also, but there is no other finding. Everything is normal. X-ray is also normal. So I sent for MRI. Maybe, may not be, who knows, but then you have to think like this also. So some questions for you. Someone tell me, left side, this one, which sequence and which plane? Someone tell me.
Sagittal plane.
Sagittal plane sequence.
STIR.
Yes, STIR. I did not talk about STIR much, but I told you that here fat is white, but I mean CSF is white, but fat is not white. That means it is water is white, STIR sequence. Okay. And so this one, which sequence? Right side. And this one, tell me.
T1. T1.
Yes, this one is T1. This one is T1 because here fat is white and CSF is black. CSF is black. So this is T1 sequence. Okay. This is which sequence and which section? Section at which area? Tell me. This is which section? Section
Axial.
what?
Axial
level?
sequence.
At what level?
Vertebral
Axial
body.
section?
Lumbar.
Lumbar level everyone knows. At
Vertebral body.
But
pedicular level, pedicle. These are
pedicle level.
vertebral body, pedicular level. It's okay. And this is what your T1 or T2?
Black.
See CSF. See the CSF.
T1. Black.
Yes.
T1.
This
T1.
whole black ball should be there in T1 only. In T2, it is black dots in white part. Okay. And STIR cannot be because this is there, this fat part. Okay. So this is which sequence? It is showing at least.
T2 sagittal.
Sagittal.
Yes, T2 sagittal section. Let me tell you some other thing. So, okay, no, this picture is not good. Anyway, okay, this one. By seeing this picture, can you say what is the T1 or T2? Here, say you are not seeing this area. Okay, this is fat area, but you are not seeing. Okay, so tell me which other areas can tell you that this is T1 or T2?
T1. CSF is
Black.
Think again. CSF is black. Where do you see the CSF?
I think it's T2 because you have the disc, there's whitish, and the transforaminal, which you have the fat tissue is white as well.
Yes. See, this area is fat. This is a foraminal area. So these are small roots and around that all fat. So you can see fat is what? Okay. Now you have to find some water because you cannot see the CSF here. So you see this part. You see this part. These are nucleus pulposus and water is there. So water is also white. Okay. So okay, someone tell me if someone is hard. What are these roots? I give you two choices. One is exiting root, one is traversing root. One is lumbar root, one is sacral root. So I told you these are lumbar roots. These are exiting roots. Means they are exiting through this foramen like this. These are lumbar roots and exiting. And these, I mean, you just remember the lumbar spine. Sacral foramens are posteriorly placed. So these are all sacral, will come out through the sacral foramen one after another. So they are posteriorly placed. So these are sacral roots and traversing roots. Means this is at the lumbar level. At this level, they are traversing. They will come out caudally. Okay, so these are traversing roots and these are exiting because this is one foramen. So here it is just exiting. Maybe this is exiting here or this will exit just below, but then no, this is exiting here only. It is near the foramen. So this is exiting here. So these are exiting roots and lumbar roots. Okay. I think for today, okay, last one, two. Okay. Here, this question, this is which sequence and which section? Someone please tell me. Sagittal section and sequence. CSF is black, so
T1.
T1. So after a few days, it will be much faster. Nowadays, now wherever you get an MRI, immediately you see. So this is last question. Let us see T1 and T2. So by seeing this area, can you say anything?
Change type 1?
Yes, type 1. Because you will see this area, not the disc area. Okay, disc area is not edematous. Edema is here. So in T1 it is black and it is white. So it is modic 1, modic 2 both white, modic 3 both black. Okay, so T1 is edema, water deposition as problematic for us. Okay, so for today this much only, 7:30. We will, if anyone has any confusion or anything, later tell me next day. Or anyone wants to ask any question at present? Okay, then good night. Next day we'll talk. Thank you.
Thank you.
Thank you.